שיש פה אנשים שבאים מהתחום הווסטיבולרי וגם אנשים שבאים מהתחום של פיזיותרפיה התפתחותית, ואנחנו מקווים שכולכם מאוד מאוד תהנו. So our wonderful lecturer for tonight is Dr. Jennifer Christy. I had the honor of actually visiting Jennifer at her lab in Alabama, the University of Birmingham in Alabama, a few years ago back. Jennifer is a professor at the university. She is one of the leading professors, one of the leading researchers, I could say this, right? One of the leading researchers in the world in the field of pediatric vestibular rehab. She also teaches worldwide vestibular rehab courses for physios mostly, and her research fields are pretty wide, so she'll talk about it in a minute. And our lecture for today is about vestibular rehab in PED, so we really hope you're going to enjoy this. And Jennifer, go for it.
All right, thank you so much. I'm so honored to be here. I'm going to go ahead and share my screen and start the presentation. Let's see. Okay, let's see, it's not working. All right, so I've shared this screen. Hang on one second. This worked a second ago, of course, when we were working on it. So I'll share screen 2. Let me do this. Before I share, I'll start my presentation. How about that? Hey, why don't you pause the video just for a second so I can get this going here? Maybe.
Jennifer, you want me to stop the share and you could start the share again?
Let's see, hang on one second. Yeah, I'm having a hard time starting my, let's see.
I'm gonna try to stop it and you can.
Technical difficulties, let's see. Okay, let's see if it works now.
Yeah, just try to share.
Okay, let's go ahead and let's see. We can, it did it now. So let's see if we can do it when we share. Share screen 1. And there we go. Okay, we got it.
Great, amazing.
Okay, so you can start the recording again. All right, it's so great to be here. I'm in Alabama, but I feel like I'm in Israel with you. Beautiful people, and I hope you're all doing well through this crazy time. But I was so honored that Moshe asked me to come and speak to you about one of my favorite topics, which is working with children with vestibular dysfunction. And so first I'm going to just introduce myself a little bit. I live in Birmingham, Alabama, which is right here. You probably all know New York, California, but I'm down in the South where it is just such a beautiful city. And I will show you a little bit about what the city looks like. So Birmingham is in the middle of the state, and this is what it looks like. It's really pretty. This is my university. So I'm at the University of Alabama at Birmingham, and it is a research university. We have so much fantastic research going on, and I also have a lab. So in my lab, I have a rotary chair. I have all the vestibular function testing equipment. And so I'm able to test all parts of the vestibular system in adults and children. And so it's a lot of fun. In addition, I'm the program director for the Doctor of Physical Therapy program at UAB. So as you can imagine, we've been having to move all of our classes online now. So that's been a big job. So I'm going to go ahead and get started. And I know that there are people on here who may have a lot of knowledge about vestibular anatomy and physiology, and then others maybe you need a little refresher. So I'm going to try to give a little bit of anatomy physiology review, but my main objective is that you will appreciate how children could potentially that their balance and their motor skill deficits could potentially be related to vestibular deficits, whether that be a problem in the peripheral vestibular system, all right, in the inner ear, or in the brain and the central nervous system connections between the peripheral vestibular system and the brain, right? So this slide represents a couple of journals that have recently come out from the American Speech and Hearing Association, and these journals have articles in them, these issues that are just about vestibular rehab and testing in children. So you may want to check these out. All right. So like I promised, I'm going to give just a quick little overview of the anatomy and physiology of the vestibular system. So this beautiful organ is teeny tiny. So you can see this is a 3D printed model of what it really looks like. Let me get the green. I have a green one too that might show up a little bit easier. All right. There we go. You can see how tiny it is. It's about is about the size of the end of your finger. And it has 3 semicircular canals and 2 otolith organs. So it has, and they're positioned in the perfect direction so that when your head moves, that this little organ can detect any movement of the head. It can detect gravity. It can detect when your head tips. It can detect how fast your head moves, right? And the way that it detects it is with the hair cells that are located within the ampulla. So this little bulgy part at the end of each semicircular canal has these little hair cells, and there's fluid inside of these semicircular canals, so that when you move, it moves these hair cells in such a way that lets the brain know the direction that you moved, the velocity that you moved. These 2 beautiful otolith organs, the utricle and the saccule, are unique because they have the calcium carbonate crystals, the otoconia, sitting in them. And so these 2 organs are able to detect linear movements. They're able to detect gravity. And if you are familiar with benign paroxysmal positional vertigo, sometimes those crystals break free and they fall into the other canals when you lie down, and they give you severe vertigo. It makes you think you're spinning. We're not going to talk a lot about that today. Benign paroxysmal vertigo is not that common in children unless they have some sort of a trauma, like a concussion or a head injury would be the reason that they may have BPPV. All right. So all of these semicircular canal, the utricle and the saccule, are connected to the brain through the 8th cranial nerve. All right. So it receives the information, it goes through the 8th cranial nerve, and the 8th cranial nerve is divided into a superior and an inferior part, all right, which innervate different parts of the vestibular system. The vestibular system is fully formed by 20 weeks gestation. So it begins to form very early in embryology. It is a part of the ectoderm, which is the same embryologic layer that the brain and the spinal cord and the eye are developed from. So by 20 weeks, the fetus has a fully formed vestibular system, and their brain is beginning to detect movements. So when that baby is born, if you were to move their head side to side, you would see the eyes moving opposite of the head. If you were to take that baby and tip them, even though they're not strong enough to lift their head, their brain wants to bring that head vertical. If you put that baby on their stomach, they're going to immediately lift and turn their head. So they are aware of head movement from birth. However, think about the kid who is born without a functioning vestibular system and how that can impact their developments. We're going to talk a little bit about that now. All right, so this is called the peripheral vestibular system. And I've listed a few diagnoses that children have that are known to affect the peripheral vestibular system. So if a child is born with severe, profound to severe sensorineural hearing loss, that means that the cochlea is not functioning well, or the 8th cranial nerve, the cochlear part of the cranial nerve is not functioning well. If a child is born with severe to profound sensorineural hearing loss, then it is also highly likely that their vestibular system is also impacted. It's not always. There are some children who have no hearing at all. They get cochlear implants and their vestibular system is fine. But if a child has sensory neural hearing loss and cochlear implants, or they don't have cochlear implants, it is highly likely that they're going to have vestibular dysfunction. And so they need to be tested and potentially go through treatment to help them with their development. Otitis media with effusion, if it is severe, it can affect the vestibular system long term. So those kids with lots of ear infections, lots of chronic ear infections, I'll turn on my little laser pointer here, could have vestibular dysfunction and need further testing and treatment. Chemotherapy. So we don't know the effects of long-term chemotherapy on the peripheral vestibular system. We do know that cisplatin chemotherapy affects the cochlear hair cells. So why would it not also target the vestibular system? That's something that we need to look further at. But I would say if you are working with children who have had chemotherapy, that it is that you should do a screen of the vestibular system. Children with scoliosis, especially adolescent idiopathic scoliosis, there's some evidence I'll show you that the peripheral vestibular system is positioned differently in these kids. Is that contributing to their scoliosis later? Because maybe they think that this is straight up and down rather than actual straight up and down. Same thing with torticollis. You know, there's been some case studies come out where these children with torticollis that, you know, typically if a child has torticollis, it just means that their sternocleidomastoid is tight. And so the therapist will take the baby and stretch them out and then they're fine. But you have those kids who, even though you stretch them out really well, they still want to hold their head like this. Do they have something going on, perhaps in the utricle and the saccule? Cytomegalovirus. So children with congenital cytomegalovirus, a lot of them have sensory neural hearing loss, but a lot of them don't. Some of them are asymptomatic. And what we're finding in our lab is that even these kids with asymptomatic CMV have some evidence of vestibular dysfunction. So it affects their balance and it affects their dynamic visual acuity, which I'll talk about in just a minute. And then there is some evidence that kids born late preterm, so you have these premature babies that do get followed because of how premature they are, but then you have the kids who are late preterm, so 36 to 40 weeks, and there's some evidence that they also have a vestibular dysfunction. All right, so these are some pediatric diagnoses that affect the peripheral vestibular system, so that affect this. All right. Now, this is what I am just super interested in, because most of the kids that we will see in physiotherapy have some of these other diagnoses that are affecting the brain, right? And so what we've done in our lab is do some vestibular function testing on kids with some of these diagnoses, specifically cerebral palsy, right? We've done, and so what we're finding is that there is evidence of damage in these diagnoses, not to the peripheral vestibular system. So their inner ear is fine. Their hair cells are functioning well. Their nerve is getting the information into the brain, but it's these central pathways. So if you look at this picture here, this is the medulla, and this is the pons and the midbrain, all right? And so the 8th cranial nerve, which connects to the peripheral vestibular system on each side, takes that information into the brain stem where you have synapses in the vestibular nuclei. And then that information goes all over the place, all right? This slide shows it going up to the cranial nerves 3, 4, and 6 to move the eyes opposite of the head, because one job of the vestibular system is gaze stability, so that when I move my head to the left, my eyes will move to the right. If I move my head to the right, my eyes move to the left. If I tip my head up, my eyes move down. If I tip my head down, my eyes move up. So it keeps the eyes stable when you're moving around. If you're a kid, you're playing and you're wanting to keep your eye on the toy that you're looking for. All right. So some of these central connections, other central connections include the connection between the vestibular nuclei and the thalamus and the cortex. And this is the part of the central vestibular system that tells you where you are in space. So am I tipped this way? Am I tipped that way? It lets your brain know where you're tipped. All right. And central also includes the, not shown here, but the pathways going down to the spinal cord for balance. So these diagnoses that tend to be affecting the central nervous system, there is evidence that they do also affect central vestibular pathways. All right, so we have migraine, concussion, which we've done some studies on that that I'll talk about in a minute. Developmental coordination disorder, there is a huge connection between, the cerebellum and the vestibular nuclei. So, and the cerebellum is what drives the vestibular nuclei. They communicate all the time. There's even a connection between the peripheral vestibular system and the cerebellum. And so the cerebellum is involved. And children with developmental coordination disorder, there's some evidence of problems in the cerebellum and the vestibular connection. Children with tumor, all right, we know that children's tumor, the posterior fossa tumor is the most common tumor in children. And if you think about where the posterior fossa is, it's right here where the vestibular nuclei sit, right? Torticollis and scoliosis, we talked about the peripheral potential problem, but what about a central pathway problem that causes the child to think they're tipped? And so they think this is straight up and down, which then it develops into a scoliosis. There has been some evidence that children with autism have evidence of vestibular dysfunction. Cerebral palsy, we found that, again, like I said earlier, their peripheral vestibular system was fine, but there was evidence of central vestibular pathway dysfunction. Myelodysplasia, children with spina bifida typically or can have hydrocephalus and an Arnold-Chiari malformation. And so that Arnold-Chiari malformation could cause damage to these central vestibular structures. So in addition, so with our kids with spina bifida, we tend to look at can they walk, can they move, we need to stretch them, we need to give them braces, but should we be looking at their gaze stability, which is something that could really impact their life. And then children with ADHD, there is some evidence that vestibular rehab actually helps these kids as well. So just some considerations for both peripheral and central common diagnoses. Okay, so I wanted to just talk a little bit about our work in athletes with concussions. So this paper was published, this is on college-aged athletes. And similar to other studies, what we found was that their peripheral vestibular reflexes, so the vestibulo-ocular reflex, was completely fine. The VEMP test, which the vestibular evoked myogenic potential tests the saccule part of the vestibular system, that was fine in these athletes with concussion. But what we found was the tests that we think look at central vestibular functions, such as the subjective vertical and also VOR cancellation, the visual vestibular interaction was damaged in these athletes, and the tests that we did were sensitive to pick that up. And they also had poor postural control. All right, and then this study is the one that Anwar Al-Muteri, who is living in Kuwait, she was my PhD student, that we looked at children with cerebral palsy in doing the vestibular tests. So we did the rotary chair with them, which looks at their vestibulo-ocular reflex. And we did also the vestibular evoked myogenic potential test, which looks at the saccular function, at the otoliths. And similar to people with concussion, we found that their peripheral vestibular reflexes were intact, but they had problems with subjective vertical, problems with canceling out the VOR, so that connection between the visual and vestibular systems was messed up. And then we just published a study looking at clinical measures and found that there were some of those clinical measures that were abnormal. So we think that our rehab, even though we're not going to be looking at necessarily the gain of the VOR as we're doing our exercises, we will potentially be impacting those central vestibular structures. Okay, and then this is the paper that looks at, there's a potential link between adolescent idiopathic scoliosis and the position of the vestibular system. So in this paper, just in summary, what was found was that there was one side of the vestibular system that was positioned out a little further than the other side in the adolescents with scoliosis. So is there a connection between scoliosis and vestibular dysfunction? This paper came out in 2012, and it was an epidemiology paper that showed that many children in the US do have complaints of dizziness, and a lot of those are not picked up. So what we found was that, yeah, these kids would complain of dizziness, but they didn't complain as much as adults, right? And so the kids are just like, okay, I'll just shake it off. I'll get used to it. I don't really know what normal is. And so they were not getting treated, right? So very few of them received the healthcare. And so this is rationale for why we need to look at the children with the diagnoses typically resulting in vestibular dysfunction and test them. All right, so this just shows the research on the children with vestibular dysfunction. You know, what are they experiencing in their life? Why do we even care about this? We care about this because children with peripheral vestibular dysfunction, they have progressive gross motor delays. So they're delayed. Now, they tend to walk, they walk late. They can run clumsily, but if you ask them to do high-level things, they don't do it. How does that impact their life? Later in life, they're not playing sports. They're not asked to be on the, kickball team. And so we want to impact that with our interventions, right? Impairments in postural control, their balance is horrible, especially if they're walking on compliant surfaces like the sand at the beach, especially in the dark or with their eyes closed. So anytime that the floor is not stable and anytime that the environment around them is moving, they're going to struggle, right? Because the vestibular system allows you to resolve those conflicts. If they don't have a vestibular system, they're not going to be able to do that. Okay. Decreased gaze stability. So like I said, one of the jobs of the vestibular system is that when a kid moves their head or anybody moves their head, their eyes stay stable if they want them to. And so this is impacted with children with both peripheral and central vestibular dysfunction. It's affecting their reading. It affects where they think they are in space. All right, we've showed that with research. Children with vestibular dysfunction tend to have gravitational insecurity. They tend to not like to be put in certain positions. Right? And motion sensitivity. Visual vertigo. So the kid is really, doesn't like when things are moving around them, right? And then poor spatial navigation. There's some evidence of a connection, or there is evidence of a connection between the vestibular nuclei and the hippocampus, which gives a child development of spatial navigation. And in this study, or in a few other studies, they looked at mice with bilateral vestibular loss. They used the mouse model, and those mice could not navigate their way to find the cheese, which is sad if you're a mouse. All right, so here's the an old study where we show the progressive delay. And if we tested 28 kids with severe to profound sensory neural hearing loss and hypofunction that we confirmed with a rotary chair test. They sit in the chair in the dark, and they the chair moves them, and we measure their eye movements. That's how it's done. Or we spin them and look at their time constant, which is beyond the scope of a 1-hour talk. But these kids with no peripheral vestibular function, they were way below the 0 on the standard score. So 0 means they're functioning similar to everyone else. They were progressively delayed. When we tested them a year later, the delay got worse. So it wasn't like they were catching up, right? So they need help, all right? The sensory organization test is what we've used in most studies to look at their postural control, all right? And so condition 1, they're standing still with their eyes open. We look at their sway. Condition 2, we have them close their eyes and look at the sway on the platform. Condition 3, the wall moves, but the floor stays stable. Condition 4, the floor moves, but the wall is stable. So we're looking at their visual effectiveness. Conditions 5 and 6 look at vestibular effectiveness. So they are standing on a platform with their eyes closed, and the only thing to resolve this conflict is the vestibular system. And then 6, their eyes are open, the wall is moving, so it's similar to walking on sand and looking at the water at the beach. All right. And what we did was we calculated effectiveness ratios and looked at some development, right? So 3 to 4-year-olds, it's a stair-step development as you would expect, right? 3 to 4-year-olds were not like adults on somatosensory, vision, or vestibular, right? Between the 4 and 6 years of age, the children tend to transition from a very visually dependent state to now a somatosensory adult-like state, right? So by the time they turn 3 years old, they're using somatosensory well, all right? But there's before the age of 4, they're still going with vision, even when vision doesn't help them out, all right? So vestibular, though, does not become mature until after age 15 years. Right? So by age 7, visual and vestibular effectiveness are good. But after age 15 years only does vestibular become adult-like. Okay? So here's a child who has bilateral cochlear implants, no vestibular system, and he's on the SOT. So you could see the wall moved and the floor was moving, and his brain did not realize that until it was too late for him to correct himself. So this is what a kid with bilateral loss would look like, and they would fall a lot. All right. And this just shows that children with hypofunction not only have problems with the vestibular use for postural control, but because vestibular, vision, and somatosensory systems are interdependent, they also have deficiencies using vision and somatosensory for balance. All right, so I'll say that again. So you would expect that someone with no vestibular system would have problems with conditions 5 and 6 on the SOT. So they would fall, you know, when they were needed. That makes sense. But children born with no vestibular system also do not develop the use of their visual and somatosensory systems very well. So we can work on that in therapy. Another test that we did in the research was the toes up tip test. And so this looks at the ability of the vestibular system to detect that the body is moving backwards and to send information down the vestibulospinal tract to get you to correct before you have to take a step, right? And what we found in the children with hypofunction was that the latency of this response, so we measured the latency on their tibialis anterior and the soleus. The soleus was normal, but the tibialis anterior was much later than it should have been. Okay. All right, so if we look at, this is the EMG response of that test. So you would expect that the soleus would kick on first when you tip somebody back, a toes up tip, followed by a very quick response of the tibialis anterior, all right? And the quadriceps and hams should be very silent. But a child with sensorineural hearing impairment, they kicked on their soleus, the soleus stayed on, the tibialis anterior came on way later and stayed on, and the muscles were just going to town to try to keep that kid up. So can we impact the work that the body has to do with our interventions? All right. So the dynamic visual acuity is my favorite test because it tests the ability of the child to use their VOR in a functional way. So what you do just quickly is you turn your metronome on to 240 beats per minute so that you're moving the head at 2 hertz. If you move the head too slow, the smooth pursuit system can take over. You have the child identify symbols or letters on your vision chart, and you're looking at the difference between static and dynamic. And similar to adults, if they get more than 2 lines of difference when you're shaking their head, that means that they are not using their VOR very well, right? And you could do the vestibular rehab that we're going to talk about in a bit. Okay, and what we found with the children with sensory neural hearing impairment and bilateral loss was that they had, on average, 6 lines of difference, whereas you should have less than 2 lines of difference. So this means that they are blind when their head is moving. They cannot see at all. And this is a reliable test that you can use. All right. Another thing that we did that was kind of cool in the research was look at a test of reading acuity. All right. So you can see here, he is signing the words. I made this test up based on the MN read test, but look at how much his head is moving, right? And the words got smaller and smaller and smaller and smaller until he couldn't read them anymore. And what we measured was critical print size. So what was the print size that he needed to have to be able to read at a good speed compared to his reading of the speed at the largest print size? And what we found was there was some evidence that kids with hypofunction, they're having some trouble reading when the words get really small. And could it be because of the oscillopsia that they're experiencing or the visual blurring? All right, so that was a lot, but I hope you appreciate that these kids do have a problem and that we need to test them. So what are the clinical tests that you're gonna do because you probably don't have access to all this fancy equipment? Or maybe you do. The problem list, you first want to find out what are their perceived problems. What is it that they're not able to do, all right? The parent may say, hey, my kid is, if it's a baby, my kid is 7 months old and they're not even sitting up yet. My kid is, 15 months old, they're not walking yet. Or my kid is older and they're falling all the time. They feel dizzy, right? You need to make sure that the children have good glasses if they need them. Find out how they're doing in school, right? Do they have difficulty maintaining their place on the page? A lot of kids with hypofunction, they are, their teacher thinks that they can't read, but it's really because they just can't see the words very well. And they, everything's jumping around on the page, all right? Do they have frequent falls, of course, and do they play sports? What is it that they're having trouble doing? Then you're going to want to investigate their oculomotor abilities, right? Because you want to make sure that they don't have some central oculomotor problem that could be affecting their vision with head movement. So just like you would with any other patient, you're going to test their cranial nerves. You're going to do your smooth pursuits, your vergence, see how well they can come in, because that can certainly affect reading, especially in kids with concussion. Look at how well they move their eyes, their saccades. Look at their eye range of motion, their visual acuity. You're gonna, can look at their optokinetics. Look to see, do they have a strabismus or aphoria or a skew deviation, and then their VOR cancellation. So I have some videos of a kid who is doing some of these tests. Kind of noisy. Let me turn off all the sounds. You do them just like you do with adults, but you might just need to get a sticker and put it on their finger. You might, you just do your cranial nerve just like you would with adults. With babies, you can still do this, these tests, but you will just need to modify, right? And you'll just need to watch their eyes moving. Okay, so these have nothing to do with vestibular function. You're just screening the oculomotor system. All right, So the test that you're going to do to look at, to screen for vestibular dysfunction, we did publish the way to do these tests in this article. So it's in Pediatric Physical Therapy, and I have kind of the normal, you know, the kids without and with vestibular hypofunction. All right. So these are your go-tos. You're first going to just look at the eyes. You're going to appreciate, does the kid have any nystagmus at rest? Does it change directions? That's going to tell you, that's going to give you information about the diagnosis, about what you're going to do with them. You're going to look at what happens after you shake their head up. Do they have an asymmetry in the system? You can spin them in an office chair. I'll show you that. And then my go-to, or everyone's go-to really, is the clinical head impulse test, where you're turning the head quickly and you're looking at the ability of the vestibular system to detect that movement and keep the eye on the target. So very quickly, I'm going to show you, this just shows a nystagmus that is beating to the left. You can see that here. So at rest, and this person has some goggles on, so they're in the dark. When they look to the left, you'll see that it beats stronger. And so this person's brain thinks that they're spinning to the left right now. They do feel like they're spinning to the left, and that's because this person has vestibular neuritis on the right side. So basically they've lost function of their right side. So anytime that they turn their head to the right, their eye is going to go off the target and not be able to stay on target. But when they turn their head to the left, they will be fine. So that's the resting and gaze evoked nystagmus quickly. Here's a head shake test. It's kind of fun. You just shake, 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 shake. This is Dr. Sylvette Wiener-Vacher. She's amazing in France. I'm sure you've heard of her before. And basically when you stop, it might look like that. So if there was an asymmetry in the system, after you shake the head and you stop, this person again did not have function of the right side. All right. One of the tests that I developed was the modified, we call it the Emory Clinical Vestibular Chair Test, but it's basically you get an office chair, you rotate them with their eyes closed at 0.5 hertz. So you set your metronome to 60 beats per minute. And every time you hear the beep, you do one rotation. You're going to need your goggles, if you have them, your infrared goggles. You put them on and you time the nystagmus. So this is similar to the step test in the rotary chair. All right, so I'll show you what it kind of looks like. Okay, let's see. Let's go back one here. Okay, here we go. All right, so we're going to spin. We're going to take the child and we're going to spin the child, and then we're going to look at the nystagmus with our goggles. All right, so let's look in, and I have a child at the top doing it and a child at the bottom doing it. And I want you to tell me. Keep your eyes closed. Open your eyes. So do you see the child at the top? So that child obviously has vestibular function. The child at the bottom does not. There was not even one beat of nystagmus. So this kid, oh yeah, they're good, you know, and you would time it, and if they get left plus right of 29.2 seconds, then that would mean that they were good. This kid, he's spinning, spinning, spinning. He's gonna stop, and he doesn't even know that he spun. He could spin in a chair all day and not get dizzy at all. All right, so the kid on the bottom needs therapy. All right, the head impulse test, you know, I have some after we finish. I have some kids with this. I couldn't show it with the recording going on, but I will show the head impulse test here. Let's see if I can get it to pop up, and I'll pull it over. So this person, you can find these on YouTube. That's where I got this one. So she has, you see that positive there? So we flick her head to the right, and she has her eyes stable. To the left, you can see that capsicad there. Right, so this person has no function again of that right side. You see how her eyes move, right? That's to the right, and you have to move the head very, very fast for this, okay? So that was just, I just wanted to show you what that looked like, because I know some people may not have actually seen that before. All right, so I've already showed you the dynamic visual acuity test. There's a computerized version that we're looking at. It may not work for young children because they have to identify where the E goes, but you can always use the clinical chart version. Talked about the reading acuity and acuity test, and then the bucket test. So here's another way that we did the DVA test. You want to make sure that, notice how his eye is moving opposite of his head. All right. And I liked, when I was learning how to do this, I made myself a little apparatus so that I could get used to how far I was turning the head from side to side. All right, this is the bucket test. So this is a way that you can look at subjective vertical. And I would recommend doing this for children with central vestibular problems, specifically CP and concussion. So you take a bucket and you put an angle finder on the bottom and a line on the inside of the bucket. And you ask the kid to say now when the line is straight up and down. And they should be able to do it within 2 degrees or so. All right, so, and that's a reliable test. Children with bilateral hypofunction, they're not going to have an asymmetry. But this is some of the data that we got with the people with concussion. So the healthy athletes were able to set the line. So this is similar to the bucket test, but they're in the rotary chair. They're pushing buttons to set a line to straight up and down. All right, the athletes with concussion did well. This is an athlete, without concussion. An athlete with concussion, though, oh my goodness, they could not figure out which way was straight up and down. So we do think that athletes, adult athletes, so college athletes and up, that this could be a sensitive test for them. It's hard to teach a kid how to do this one reliably, right? But you can do it, right? And then we do have an app that we're working on to be able to get, data that's not just from an angle finder on that. So I know I'm kind of zipping through this, but I want to get to the rehab before we finish because that's the fun. Pediatric therapists, you will know about standardized tests. In the States, we use the Peabody Developmental Motor Scales for younger kids under the age of 7. And then for older kids, we use the BOT2. And actually, you can do the Brunick-Oseretsky test, 2nd edition, for kids ages 4 through 21, and it has a balance subscale. So I love the BOT2 balance subscale and also the bilateral coordination subscale and the strength for kids with vestibular dysfunction. So this will give you an idea of where they are in their development. All right, this slide shows you all of the vestibular function tests that an audiologist or a neurologist will do. Typically, an audiologist will do this. So physios don't typically do this. Now, the video head impulse test, a lot of physio clinics do have one of these. And so you can get an idea of the gain, not just of the horizontal canal, which is what I'm testing when I go side to side, but also the anterior and posterior canals. You can get an idea of the gain of those. This is the OVEMP test, which tests the utricle, we think. This is the CVEMPs, right? So they're contracting the sternocleidomastoid, which tests the integrity of the saccule. Here's the rotary chair I keep talking about, which tests the horizontal canal. And you can also do your oculomotors in there. And then this is the synapsis version of the video head impulse test that does not require that the kid put on tight goggles. So this one, they actually let me borrow some. We're collecting some data for children. It's not FDA approved in the US now, but I think that y'all can use this. And then this is the old caloric test where they're putting either air or water in the ears and they're looking at asymmetries. All right, so if you do your screen, you do your head impulse test or your spinning test and you think that they have a vestibular dysfunction, you're going to refer them for further testing to confirm that. All right. And then this slide shows, hey, if you want to do a caloric test, you're going to do that on older kids. The rotary chair and the VHIT can be done on younger kids. If you look at Kristen Janke's article in 2018, it describes all of these tests if you want to look that up. All right. All right, so finally, we are going to get into the fun stuff. I think it's important, though, to go over the other so that you'll understand what you're doing when we're doing these fun interventions, right? So what are we trying to do with these interventions? So we are trying to get the brain to compensate for a lack of the vestibular system, either on one side, on both sides, or a lack of central vestibular function. We're trying to get the brain to use its plasticity, right? And we're trying to do that through movement. We're going to challenge the system, right? So if the child has some vestibular function, we're hoping that the vestibular nuclei are going to adapt with our interventions are going to help them to adapt. If there's no vestibular function, we're hoping that other areas of the brain are going to substitute for a lack of vestibular function. And then if the child has symptoms, we're hoping that when we do these movements with them, that their brain is finally going to say, oh, this is not so bad. And they're going to, help them to habituate, right? The boring adult version of these exercises are shown here, all right? So we have ×1 viewing where they look at a letter and they shake their head. I'm just going to kind of turn these on here. So you see she's shaking her head while she's keeping a letter in focus. This is a ×2 viewing paradigm, all right? This is, a little bit more advanced, the ×1 on a checkerboard, all right? And this is a gaze shifting exercise, all right? So this is the boring adult version of it. We don't, this is kind of what the exercises I'm going to show you are based upon, right? And what Michael Schubert and others have shown is that when you do these exercises, it actually does work, right? So this is a video of this is a picture of the video head impulse test. So when the head moves quickly, the eye lags behind and then catches up, okay? And so we think that with our exercises, we're doing two things. One is we're actually increasing the gain of the VOR, right? So we're adapting at the level of the vestibular nuclei. Another is that we're improving the compensatory saccades. So when they move their head, no, they're not gonna have a VOR because they have vestibular loss, but the brain is somehow producing a saccade to move the eye opposite of the head, all right? So in order to do that with children, we need to make it a game. We need to make it fun for them. They're not gonna wanna look at a letter X and just move their head fast, right? And so we're gonna make it a game. We're gonna make the variables interesting. We're gonna use pictures. We're gonna use game boards, PowerPoint slides. We're gonna use little videos of books and make them read while we are turning their head. All right, there's so many variables that you're gonna change when you're doing this. All right, you're gonna begin with a bigger optotype and progress to smaller, all right? All right, so I'm going to show you a video now of a child trying to do the ×1 viewing. So they're moving their head side to side, and I'm having her read a book. And I want you to notice something here. So notice that when she's really trying to read, she's stopping her head, okay? She's having to hold the book and turn her head and read. So this isn't working. Don't do this. This is what not to do, okay? You go like that, okay? You ready? And go. Same thing here. So when she's moving her head up and down, she's doing a little bit better, keeping it moving, but she's not moving it very fast, all right? So how can we impose some head movement? So here she's bouncing on a ball. She's having to use her VOR. Now she's going up and down, so she's getting some linear movements, but she's getting a lot of perturbations here. Now I'm trying to move the book opposite, and she's saying, you know what, this is not working for me. It's too hard, okay? So the way you know that she can see it is she's actually reading the words on the book, all right? Here's another one. So I'm asking her to find, so I'm asking her, I have a game board here. I've got pictures all over it. I'm swinging her in the swing, and so she's getting some head movements, and I'm asking her to find certain objects on there, right? So again, all of these exercises are trying to improve the dynamic visual acuity, their ability to see with their head movement, right? You can use a sit and spin. All right, so I'm showing him flashcards here. And a child with bilateral loss will not get dizzy, so you don't have to worry about that. All right, so he's getting some fast head movements, and it's fun for him. Okay. So that's tons of movement. You have mom bouncing the kid on the ball. Look how much her head is moving.
What is that? A what? Oh, yeah. What is that?
I don't know what she said, but I think she got it right. All right, so you're just showing them pictures. So that's another way to get these exercises. All right, you can have them jump on a trampoline. They're getting some cardiovascular movements. Now again, all of these are kind of linear up and down, right? We need some side-to-side movements with these kids. All right. Okay, so the next thing that I'm going to do is I'm going to show you this. I made some video books, all right? So what I did was I took pictures of a bunch of children's books and created a PowerPoint video. I put all of the pictures on a PowerPoint slide and created a video. So all the parent has to do is to go to the video, hit start, and they're having their kid turn their head. So right now, wherever you are, and hopefully everybody's still here, I want you to turn your head right, left, and I want you to read the book as I play it, okay? All right, so you're reading it. I do not like them. Now turn your head faster. Kind of make the words jump. Now back off just a little bit. That's where you want them, right? When you do that, now you're going to be turning the head of the kid. I would not like them here or there. I would not like them anywhere. So the book actually changes. The parent is standing behind the kid, turning the head. And now try up and down a little bit. Up and down, up and down. All right, and if they get finished with the words, they can look at the pictures. And you're going to go for 1 to 2 minutes with the kid. All right. If you got dizzy, then you know how the kid would feel. The kid would get dizzy as well, right? You're going to set a metronome. Okay. Moving along. I hope y'all are getting this. I can't tell because I can't see anybody. All right, let's see. Okay, here we go. So this is me doing so I have a book video here. It's not the book, it's just words. So this would be a little bit less, it would be a little bit less difficult.
Here we go.
Okay. So I'm turning his head. Now I'm doing him at 2 hertz. A child with hypofunction, you're not gonna be able to go that fast. You see he's reading it and the slide is changing with new words. Right, and he's, you know, somewhat enjoying this. All right. All right, and here's an older child doing the same thing. I'm gonna do her, I think, in pitch head movement. So the parent would start the video. All right, it's the same book that we just read. Okay, so it's a lot of fun for the kid. All right, so I just wanted to show you that this actually does work. So this is a 10-year-old kid who has congenital cytomegalovirus. He was born with no hearing, and he got bilateral cochlear implants at a very, very young age. He did not walk until probably 18 months of age, has never gotten therapy before. All right, so what I'm doing here is the computerized dynamic visual acuity test. Okay, so you wear a rate sensor, and I'm turning his head, and he tells me what he sees on the computer. All right, the data that we get from that is that whenever I turned his head to the left, he had 5.5 lines of difference between static and dynamic acuity. That's bad. Remember, 2 lines is normal. When I turned his head to the right, he lost 8.5 lines. So this kid could not see with head movement. Okay. All right, now I did the V-hit. So this is the Synapses Video Head Impulse Test. And you can see here, hopefully, that I moved his head and his eye lagged way behind. All right, so I moved his head to the left and his eye was supposed to move to the right at the same time that the head moved to the right. But I mean, he did not even have any what we call covert saccades. His saccade was really late. He has no vestibular function. So this is what that head impulse test looks like. So he's looking at a target on the wall, and I'm measuring his horizontal canal. So basically no vestibular function at all. I taught his babysitter how to do the exercises, and look how slow they're going. And he struggled with reading. This kid struggled with reading in school. The babysitter said that she had to put a ruler down on the page so that he could keep his place on the page. All right. So we did this for several weeks. All right. So this was September 5th was the initial eval. And then September 20th, we looked at him again, and he had already improved his dynamic visual acuity. So that was good. All right. We continued to train him for 4 more months with testing every 2 weeks. And we did a dose of 10 minutes per day and up to 160 beats per minute. So 240 is 2 hertz. So 160 is a little bit slower than that, but that's still good for a bilateral. We added some balance training with him, and he improved to 3.5 lines of difference on the left and 3.8 lines of difference on the right. So that's huge. That's great. And his babysitter said that he no longer had to use the ruler on the page. All right. So we improved him a lot. All right. So this is him trying to stand on the phone with eyes closed.
Okay, so what are you gonna do? Open your eyes, I'll get reset.
He had no idea where he's on a piece of foam, so it's not easy for him. So he couldn't really do it very well. And then after I gave it to him to work on for a little bit, he got much better at it. So this is really huge for him to be able to do this. All right. So, all right. Gaze shifting is another type of exercise where you move the eye and then you turn the head. All right, so you move the eye to the target and then you turn the head quickly to the target, move the eye the other way, head the other way. This is the boring adult version, right? Let's see. What if you had a bunch of cute little pictures and you turn the kid's head left and then point to the minion, turn your head right, point to SpongeBob, right? So you're making them use their eyes and their head, right? Or you had the letters on the zebra kind of busy, or you put, so I put pictures all over the room and I'm having the kid go find a certain picture. So she's having to move her head, she's having to run. It's sort of like a matching game. So that's another way to get that gaze shifting. All right. So she's having to turn her head. She had to turn her head right, left. She's having to tell me what is on the pictures. She's doing gaze shifting. All right. And she wanted me to tell you that she put her makeup on, her eyeshadow on just for the video. All right. You can do eye-hand coordination types of stuff. Just anything that's going to get them to have to focus their eyes while they're moving their body. All right. There's an elephant game where the elephant shoots the picture up. You can have them not only catch it, but also identify what it is. Really, you can have them chase you around and identify letters on a busy background. All right. And then, you want them to do it. You want them to include this in their daily life. I know we're going way over. Most y'all stop me if you need me to stop, but I'm going to keep going. All right. Okay. So before school, they may do a little bit of it. I'm fine that the kids before school don't do anything, but just help them to work this into their daily life as much as possible. That's something we need to study, is what is the dose that's required. All right, you're going to follow up and you're going to test DVA. For habituation, if the kid is complaining of motion sensitivity, you're going to find out what's causing the problem, and you're going to do that motion, but only up until they're about to have symptoms, right? So you don't want to make them sick, but you don't want to do it to where it doesn't bring on symptoms at all right? And you're going to do that throughout the day. All right, the last intervention, most of the physios know how to do balance intervention, but now that you appreciate kind of that children with vestibular dysfunction have trouble using vision and using somatosensory information for balance, it might impact how you develop your balance exercises. So if you want to push use of vision, you're going to have them stand on a compliant surface like foam, and you're going to have them really use their vision to focus on stable things, right? If you're going to push the use of somatosensory, you need to have them standing on a stable floor, but then make the background very busy. All right, sorry about that. Hang on, let's get back to where we were. All right. All right, good. So these are some, things that we did in the research with kids. We had them sit on T-stools and bat balls. So they're really having to focus on what are their feet doing while the busy visual environment. We used scooter boards to give them perturbations. We played badminton with them. Notice his wide base of support. We got them on these little T-stools and made them sit with their feet together. So just tons of things that you can do with them. We find that kids with no vestibular function, no peripheral vestibular function, their strength, their proximal strength is decreased. And so working on these big body movements is going to help them a lot. Okay. The research shows there's only one big study where we actually measured vestibular function. I know we need to do more, but the research shows that we were able to halt the progressive developmental delay, and we were able to improve their dynamic visual acuity with this program, with these exercises, all right? Some other studies that have been out there have showed, there was a systematic review done, which showed, that we really do need more studies, all right? This was an interesting study that I thought was kind of fun that shows that, hey, if you do vestibular rehab in your kid with ADHD, that it makes them smarter, basically. So I thought that was an interesting test. So I know that I jumped through this. I ran through this so fast, but I was really just trying to give you all an idea of the testing and the intervention. So I hope that I didn't go too fast. Maybe you can go to the video and kind of go through it, pause it, go through it again if I went too fast for you. I'm always open to questions. We also have a Facebook page called Pediatric Vestibular Therapists. And if you would like to join that Facebook page, I do require that you answer a few questions, like, are you a physical therapist or audiologist? And have you had some training in vestibular rehab? I just don't want people getting on there that don't really know, because we want to keep the conversation very focused, but I'm happy to add you to that. I'm also happy to share my video book with you if you want to use that on your patients. So with that, I will ask the moderators to, we're only 6 minutes over, right? Or is that right? Yeah. To open it up for questions, or I'm happy to go back. But definitely, I think we're going to stop the recording, and I can show you some of the other videos of the patients if you want. So that's it.
Okay, good. So I think it was a wonderful presentation, really wonderful, wonderful, brilliant. And
I wanted to spend 5 hours, but we just have the 1 hour. So
yeah, it's here. It's like, it's already past 10 p.m. So a lot of people have to go, the kids. But I mean, yeah, I know, and we can do this again. Tomel, please stop the recording so that we can continue.
Okay, Jennifer, you want to take questions first or the videos first?
Whatever y'all want to do. If y'all want to do questions with the video, that's fine. Or if you want to stop it, I'm open to whatever.
Okay, we just figure we can pause the video and open it again for the question if you want.
Okay, so you could try maybe let's see. Oh yeah, BPPV in peds. So how prevalent is it, or how uncommon is it, as far as you know?
Yeah, as far as I know, there was a systematic review that came out of, I think, China or South Korea, maybe, that, it kind of went over the prevalence of it. But it is not very common in kids. It is, I don't know the exact prevalence number, but most clinics are finding that the kids that have it are the kids who had some sort of a head trauma. Right? So it's not like adults where they just spontaneously get it. There's a few case studies that show kids after cochlear implant getting vestibular, getting BPPV, and they get it after they get off of a roller coaster. So, you know, I would say if the kid presents with symptoms of BPPV, go ahead and test them just like you would with adults. Go ahead and take them into the Hall Pike or the roll test. But it is not very common in kids just because they're, you know, their vestibular macula tends to be very sticky, you know, and the crystals are not kind of dislodged like they are in adults as easily.
Okay, we got another question regarding vestibular impairments in younger preemies. So you were talking mostly about late premature infants, but is there more info about the younger kids?
Yeah, you know, what we're finding is that, you know, the young preemies would tend to also have cerebral palsy. And those children, I would say, go ahead, and you don't need to send them for peripheral vestibular function testing like rotary chair or caloric, but you do need to test their dynamic visual acuity. And of course their balance, which we always test their balance. But what we found in the kids with CP, which to me would be the really young premature that also had some sort of a brain damage, that dynamic visual acuity is impacted. And so doing those VOR training exercises with them may help. And then also having them work on compliant surfaces with their eyes closed. So really having them work on their use of vestibular information for balance.
Okay, and regarding autistic patients with autism,
Yes.
so they tend to move their heads from left to right, right? We know that many times fast. And well, how do you understand this in the sense that how does this contribute in the vestibular aspect?
Yeah, that's a good question. My hypothesis is that their peripheral vestibular system is probably fine, right? Because there's really no reason, you know, why that would be damaged. The connection to the vestibular nuclei is probably fine, but it's that integration of vestibular information, visual information, and somatosensory information, which happens in the parietal lobe. You know, that integration is causing, so all this sensory information is coming in, and you know, children with autism, it's been shown that they're not able to sort of drown out certain types of sensory information, and so they're almost craving that movement, that head movement. And so, you know, I think that that's what it is. I think it's kind of the sensory integration part, so more of a central problem rather than a true peripheral vestibular dysfunction. And that brings me to another point. You know, your kids with central problems, like, you know, kids with autism, you know, some of them do move because it makes them feel better, right? But then you have your other end where, you know, the kids with cerebral palsy, and they don't ever get to hang upside down, and they don't ever get to do flips, you know, like typical kids that are doing cartwheels and all of that. So we really need to move our kids around and stimulate that vestibular system, you know, and even if we're not having them focus on something or whatever, just getting them moving, getting them flipping, you know, have their parents hang them upside down by their ankles sometimes, you know, in a safe way or whatever. I think that's important and something that's missed.
Okay, is there a connection known to you between habitual toe walking and vestibular issues?
That is such a huge problem, and no one's really tested that. I think we need to. I think we need to take our habitual toe walkers, because for some reason they perceive that their body is normal when it's forward a little bit. If you were to push them back on their heels, what do? They think they're falling backwards, right? And so I think that there's something going on in the otoliths. There may be some, you know, kind of similar to the torticollis. So I think that would be a great study to take kids who with habitual toe walking, because no matter how much you stretch them out, they always want to go right back up on those toes, right? But there hasn't been a study done on that yet. So that would be something that would be really great to do. Just do a vent test on them, maybe a quick head impulse test. You know, I wouldn't expect that their canals would be messed up, but maybe that, you know, the saccule or the utricle may show something. That would be really interesting.
From your clinical experience, do babies that tend to cry a lot and have issues soothing themselves, do they tend to have vestibular impairments? And if so, then what do you recommend doing about it?
Yeah, you know, babies like, you know, they like to, you know, generally like to move, but I don't think that there's you know, proven connection between behavioral kinds of problems and vestibular dysfunction. You know, I don't think that that's been shown to happen, but you know, I know that moving them around does soothe them in most cases. And so it must be, you know, kind of the rhythmical, I'm sure it has a lot to do with all of the sensory input. So I guess the answer is, I do not know of a connection between babies who are, you know, difficult to soothe and vestibular dysfunction.
How
But
about babies that cry in the car?
yeah, yeah. So, you know, lately I have been getting a lot of emails about kids who get sick in the car. You know, most babies, you put them in the car and you start moving, they go right to sleep. But it seems like since we've been making kids face backwards and, you know, they have to sit, you know, facing backwards until they're a certain age, I don't know, there's something going on with motion sensitivity. And so that just requires habituation, you know, so taking them maybe in a stroller and pulling them backwards and just getting them used to that motion. Um, so, but you know, I wouldn't suspect that their inner ears would be messed up, but there's something going on centrally that's making their brain not like that motion. So to me, the appropriate treatment would be the habituation of that. So taking them on a shorter car ride and then kind of working up, which I know is hard to do when you got to get places.
Patients with CMV, for example. So the question is whether they need to undergo all the tests or work on a combination of visual and vestibular sensory combinations. That was a question.
Yeah, so, you know, this is something that's kind of new, is that kids with CMV, if they have CMV and severe to profound sensory nerve hearing loss, definitely get them tested because they probably have vestibular dysfunction. If they're asymptomatic with CMV, they're coming to see you for some reason. Probably they have poor balance or, you know, they're developmentally delayed. So I would do some of the screening tests on them. And if they come back positive, I would send them for testing. But there's people in Canada and also here, Sharon Cushing, for example, is pushing for testing of all kids born with CMV, hearing screenings for sure, and vestibular as well, because there's, you know, in our study of kids with asymptomatic CMV, we found evidence of developmental delay on the standardized test, dynamic visual acuity problems, but most of them had normal peripheral vestibular reflexes on rotary chair and VIMP. There were very few that had that. So it was like a central thing again. You know, it's one of those where, hey, they have it, they're just not using it very well. So yes, I do think that, you know, the kids with CMV need at least to be screened and followed.
Okay. Someone was asking about gravity insecurity. What would be the best treatment for that?
You know, it's again the habituation. So it's just making sure they get those experiences. And, you know, you don't want to throw them into a situation that freaks them out, because then that's going to negatively affect the brain. So you want to take them, you know, find out what is it, you know, let's say that they don't like the swinging, you know, is one thing. So what you're going to do is you're not going to put them on a swing and just say, okay, tough it out. You're going to do a motion that might be tolerable to them, but in that plane of movement. And then you're going to watch their face and say, okay, you know, let's do 3 times now, and have the parent, you know, doing it just to the edge of symptoms. So that's what I would recommend for that. But they need to get those experiences.
How about group therapy for kids?
You know, when we did the research, so the videos of me like pulling the kid around on the scooter and those, you know, sitting on the T-stools, we did those in a school setting in groups. So we did groups of 3, and I just chose an exercise each day from the visual, like we did eye-hand coordination exercise, we did a balance exercise, we did a gaze stability exercise, and then we did a just kind of gross movement exercise. So I had like a list of a bunch of different exercises, and I just chose one from each category, and we did them in groups. So you can definitely do that in groups, and it works.
Let's see. So regarding toddlers under 3 with hearing loss and cochlear implants
Yeah.
that are suspected to have a vestibular dysfunction. So at what age would you recommend to send them to a specific test, and which one?
Yeah, I would, if I would send them to the audiologist as soon as possible. So, you know, some audiologists are comfortable testing babies, others are not. So find a pediatric audiologist, and you can do a vent test on a baby. You can do a rotary chair test on a baby. Now, of course, the dynamic visual acuity you can't do until they can tell you what they're seeing. But I think it's important, even, you know, as infants, to know if they have it or not. So I would say get them tested as soon as possible, and that way the parent knows, you know, that they have it. Now, if you don't have an audiologist who will test babies, you can do the clinical light impulse test, right? You can sit them on their mom's lap, have the mom spin a little bit, and see if you see a posterior nystagmus. You can take them and tip them and see if they right themselves. Okay, so a kid with hypofunction, they're not going to right themselves very quickly. They will right themselves because they have vision and they feel what's going on, but they're not going to right themselves fast. Okay, and then for the intervention, you're just going to work on developmental skills, right? You're going to work on having like little itty bitty toys that they're looking at while you're bouncing them on the ball, you know, gently. Even though they can't really tell you what they see, you want to start early, for sure.
How do children respond to vestibular exercise in terms of practice time and recovery time compared to adults?
Yeah, we don't know that yet. The clinical practice guideline, which we're actually working on updating right now, is based on adults, and then that one study that I did with Dr. Ryan. But it says, you know, for a person with more acute vestibular hypofunction, that you would do the gaze stabilization exercises 12 minutes a day total, right? And then for the chronic, you need to do them up to 20 minutes per day. So, you know, the case study that I did with Sawyer, he was not going to do them more than one session. He wanted to do one session a day, and they did the books, you know, read the books for about 12 minutes a day. So he was able to spend 12 minutes doing that, and it worked for him, you know? And so I think you don't want to overload them with stuff to do at home, but I think if you follow those clinical practice guidelines, you know, kids tend to have more chronic vestibular, so try to get them to do at least 12 minutes a day of the exercises. You could parse it out. So when you get home, we're going to do a few, and then we'll do a few later. You just got to kind of find what works for the kid. And then you got to work it into their daily life so that they're not just stopping life and doing the exercise, you know? So, okay, let's take the kid to a park that has a lot of, you know, hills and things that they have to climb on, you know, have the kid do, you know, sport activities that require them to work on their balance, like gymnastics or karate, where they have to stand on one foot. So just working it into their daily life. But we don't know the dose yet. That's something that we need to study.
Children with DCD. So what should we add to our treatment regarding what, you know, everything you just talked about?
Yeah, so I would just test their dynamic visual acuity. So test their ability to see with their head movement. And if they get more than 3 lines of difference, add in some VOR training with them. Test their, you know, I talked about the SOT, but clinically we do the modified CT-SIV. So where they're standing on foam on the floor with their eyes open closed, and then on the foam with their eyes open closed. So if they're not able to do that, then work on compliant surfaces with their eyes closed. But if they are able to do it, then you don't need to worry about that. Kids with DCD tend to have the apraxia. They have trouble putting movements together. So you may do some dynamic balance things where they're walking and turning their head and identifying what's on the wall. So some of those gaze shifting types of exercises might help them. So I would say do those tests, and then if they're abnormal, then go ahead and do some of the exercises with them.
Okay. How about with your clinical experience with the kids who suffer vestibular dysfunction combined with torticollis? So, what would your recommendations be regarding that population?
Yeah, so that's a tough population because what you have to do is teach them what straight up and down looks like. And that's the same thing with the, the idiopathic toe walker. You got to teach their brain that this is not straight up and down. So it's lots of use of, once you get them stretched out, and that's not the problem, it's using mirrors and just cueing them to, straighten their head, or, doing a lot of head writing if they're an infant with them. So it's really just teaching them what straight up and down actually is, and hopefully the brain will adjust to that.
How about recommendations for vestibular stimuli in prematures?
So in the premature babies in the NICU, part of the kind of the common treatment is to, have them sitting up and kind of working on their head control. And so usually they don't get their hearing screen until they're about to go home. I guess, is that what, do they mean after? Is this kind of while they're in the NICU or while they're in the NICU?
Yeah, while they're in.
Okay. Yeah, so just continue to do what you're probably already doing, which is having the parent, hold them upright, turn them different ways, do your positioning with them, having them focus their eyes. We do that a lot. Smooth Pursuit is not working on vestibular, but as you're moving them around, see if you can get their attention and have them focus their eyes. But to me, that population, the biggest thing would be to get them sitting upright and, working on some head control and just getting their head in different positions, which is probably what you're already doing. So.
There was well, how are you in terms of answering questions? Because we kind of keep getting them.
Okay, I'm good.
Okay, so there was another question about a rocking bowl. So do you use that in your practice? And if so, then what are functional outcomes after using that?
Do they mean the
you spin around kids in, right?
Okay, like the astronaut board thing? Is that maybe?
Yes, so yeah.
Okay,
The
whole astronaut therapy is a little bit different than what I'm talking about here. So I think that the astronaut therapy, where you're spinning the kid, you're not really asking him to focus on anything, right? So this is more doing habituation for your, what we call the sensory kids. So these are the kids that don't really tolerate movement very well, or they are not integrating the information. So that's very different than asking someone to read while their head is moving, So it's more, I think that what they're doing is more habituation of the brain to that movement. I'm hoping that if they habituate that movement in the brain, that the kid will function better in their life. So I have not used that just because it's a little bit different outcome than what I'm used to, that what I'm interested in, I guess. So.
What do you say about jumpers?
Oh, we used to say, okay, if they have low tone, and kids with hypofunction tend to have lower muscle tone, especially proximally. So to me, you stick them in a jumper and they, are using their legs, they're pushing off. I don't see anything wrong with it for a kid with lower tone. Now, if a kid has, higher tone cerebral palsy, I would say don't do it, because you're just going to feed into that spasticity. But I think it's good for the kids with lower tone to use. And I'm assuming you're talking about where you hang it from the door frame and you're just kind of letting them jump around,
Yeah,
not for hours and hours, but yeah, it gets them moving, gets them pushing.
Okay. I think that's enough questions for tonight here.
Okay.
I think it was a wonderful presentation and lecture, and actually that was the feedback that we got. We'll probably keep on getting that feedback. I really want to thank you a lot. And as I said, I hope that we will be able to bring you over here. Yeah, so we can say that publicly now here. And Okay, so and I guess we'll call it a night. And thank you very much.
Yeah, thank y'all. Have a great night and stay safe. And just email me if you have any questions. I'll be happy to answer them.
Absolutely, yeah. Okay, everyone's very thankful here.
Okay, awesome.
Okay, good. So
Oh yeah, I'm seeing all the chat now, so that's great.
yeah, you can go over the chat and see all the thank you notes here. And we also have so the Facebook, the name of the group is written down in the chat. It's recorded, so everyone will have it. And hopefully, whoever's interested will join.
Okay.
Okay, good.
All right.
Okay, second.